Alright, hello everyone. Hi, I'm Dr. Sourabh. I'll just check in a minute that I'm visible and audible myself, and then I'll go ahead. I'll just check in a minute that Yeah, should be okay. First of all, happy Teachers Day to all my teachers and of course students as well. Students are also teachers. So I would start this session. So this session I've made a small session because adult patient with acute painful vision loss, there are not so much differentials in ophthalmology of that. There are about 5-6 main differentials. I'll give you others as well, but the main purpose of this is to how to approach any patient of any particular symptoms who comes to you. But before doing that, okay, I'll just share with you one quote which I like the most, and this is a Teacher's Day. So listen to this, uncle.
Education is not the amount of information that is put in the human brain. It must have man-making, character-making, and life-building accumulation of ideas. Then only by means of that education something can be gained in the world.
So education is not the accumulation of the knowledge. This has to be a crisp and concise learning of the basic things, and then you can build up your knowledge from there. So from there, thank you very much, Kushal, and I'm going to start today's session with a adult patient of acute painful vision loss. So each word has a meaning, and each word acute means that the patient is coming to you in emergency department, right? What can be the reason of pain in the eyes? First of all, this. Any symptoms, any situation like this comes in your exam or in your viva or anywhere, the main thing you should have some differentials in your mind. So we will write down some differentials, but what can be the reason of pain? Pain can be there when there is irritation of the nerves in our eye. Nerves which are providing some sensations. Now nerves are mainly present in cornea, okay, mainly in uvea. So whenever the uvea cornea nerves are irritated, the patient can have pain. Or when the intraocular pressure is very high, very high, extremely high, then there is the stretching pain of the cornea sclera because of the stretching of the eyeball. And there should be, in this scenario of ours today, there should be vision loss or blurred vision as well. Now when you call vision loss, when the visual acuity is actually less than 6/6. Blurred vision can be because of momentarily corneal haziness, maybe discharge. So all the three should be there. It should be acute condition, pain condition, and the vision should also be decreased in a adult patient of today. So let us see what can be the differentials, because our case will build up only from the broad knowledge if we have differentials of this patient. Always let us start with anterior to posterior, means cornea to retina. So let us see cornea first. What? Cornea has nerves. So, and cornea is a major refracting surface. If there is some problem in the cornea, there has to be some vision loss. So pain also can be there, vision loss, and an acute situation. Okay. So when there is cornea known as sclera, and when there is keratitis, mostly keratitis can be numerous causes, particularly infectious keratitis can present with acute painful vision loss. The first major differential is infectious keratitis, also known as synonymously as corneal ulcer. But in the ulcer, there is breach of epithelium, plus there should be infiltration of organisms, for calling you the patient as corneal infectious keratitis. Okay, what next comes? Next is aqueous angle. Okay, if I just see this eyeball, the anterior segment of the eyeball, cornea, I just told you the major differential in cornea is keratitis only, infectious keratitis. Then comes this angle, iris. So iris per se will not cause vision loss. Now iris problem will not cause vision loss. Aqueous means intraocular pressure. I just told you. So second major differential is increased IOP. Increased IOP due to any cause. Now increased IOP can be there in primary glaucomas, but this is an acute situation. Usually primary glaucomas, open angle, closed angle, are gradual painless vision loss. But there is a situation known as acute primary angle closure. Only in angle closure patient, the pressure can go extremely high when the pupil is dilated. There's a pupil block mechanism. And the other reasons, secondary glaucoma, secondary high IOP due to multiple reasons. Secondary acute pressure IOP. All secondary glaucomas is not acute. Secondary acute due to, again let us go from anterior to posterior. Let us see the iris. Iris, there can be neovascular glaucoma. I'm talking acute situation when the pressure is going extremely high and there is acute, painful, and there can be blurred vision or vision loss. Then lens induced. Now lens induced, lens, I hope you know, lens means phaco, and phaco, secondary glaucomas and phaco can be phacomorphic glaucomas, phacolytic glaucomas. I hope you know phacomorphic seen in intumescent stage of senile cataract when the lens is swollen. Phacolytic seen in hypermature Morgagnian stage of senile cataract, and there can be phacotopic due to ectopia lentis, due to subluxation dislocation of the lens. Topic means ectopia, and the lens is not in the patellar fossa. There can be other, can be anaphylactic, phacoanaphylactic. Previously, I mean, it's known as phacotoxic glaucoma. That also can be there, but less common. So okay, I'll write down phaco antigenic uveitis or phacotoxic glaucoma. Other names are there: lens particle glaucoma, lens phacotoxic, lens particle glaucoma. Phacolytic also known as lens protein glaucoma. Phacotoxic is lens particle glaucoma, also known as phacoantigenic uveitis. A rare thing, but that is a secondary acute IOP. Then secondary IOP can be due to aqueous misdirection, which is also known as malignant glaucoma. Hi, I can do it. Thank you very much. आपने नाम ही लिख दिया. I can do it. Very nice. Next, uveitic glaucoma. Glaucoma due to secondary high pressures. All these are due to secondary high pressures, secondary increased IOPs. Then there can be due to any hemorrhage. Hemorrhage, I hope you know, hyphema, right? Or any pigmentary glaucoma, or a pseudo exfoliation glaucoma. Now all these are differentials. Of course, they can present with gradual painless vision loss, but there can be acute situations when the pressure goes extremely high in neovascular, lens induced. Lens induced generally present as acute situations. Aqueous pressure generally produce as acute high pressures. Uveitis can be gradual, but can be when the pressure goes very high. Same goes for hyphema, pigmentary glaucoma. So first from cornea, the second one was increase intraocular pressure, right? Hi Neha, thank you. Then the major thing comes behind that is a vitreous. So when the vitreous is involved, the third major differential, first was cornea, second was increased IOP. The third, when there is acute infection or inflammation of the entire eyeball, endophthalmitis. That is infection, inflammation of the entire eyeball involving the vitreous, except the cornea sclera. Because if cornea sclera is involved, the term is known as panophthalmitis. That also presents as the same thing. But the differentiation between endophthalmitis and panophthalmitis is the cornea sclera are involved in panophthalmitis. As the name suggests, pan, everything in the eye is involved. And if the infection goes outside, that is orbital cellulitis, that also presents. But before that, let us go more behind to retina pathology per se will not have any pain, right? But secondary, like diabetic retinopathy leading to neovascular glaucoma, central retinal venous occlusion leading to neovascular glaucoma, that we have already written, neovascular glaucoma. There can be multiple reasons, mostly retina ischemic reasons. Neovascular glaucoma usually occurs when there is a retina ischemia, like in diabetic proliferative stage of diabetic retinopathy, like in central retinal venous occlusion, ocular ischemic syndrome, three major ones. So per se retina problem will not cause acute painful vision loss. Okay, then optic neuritis. Now, optic neuritis is a very broad term. Optic neuritis can have hundreds of causes. Usually, optic nerve problems will have a painless vision loss, but there are associated symptoms like painful eye movements are there. Like there can be headache, like in giant cell arteritis. So this is plus minus. This is plus minus. That's not a very important cause of acute painful vision loss. But in the differentials, in the least differentials, you can write down because there can hundreds of causes of optic neuritis. Some can have associated pain. Right? Please remember, some have associated pain like giant cell arteritis, multiple sclerosis, painful eye movements, and then of course orbital cellulitis. I'm going from inside to outside the eyeball. That's why orbital cellulitis I'm writing later on, but it's an important differential. And in the orbit, keratico-cavernous fistula. I'm talking about adult patient here, right? In children, there can be other causes also. Acute painful vision loss, like retinoblastoma, any tumor, rhabdomyosarcoma, acute painful proptosis, rhabdomyosarcoma, neuroblastoma, retinoblastoma, ruptured dermoid, ruptured sclerum. So many are there in a pediatric patient, but age group has to be taken care of because we are dealing with adult patient over here. So these are, thanks Muskan, these are major differentials. Let us just go through this, because whenever a question comes like this, or they should be have a broad set of mind. So in your mind, at least what should come? I'll just mark the important ones. This should come as an important one in your mind. Of course, acute primary angle closure glaucoma, that was previously known as acute congestive glaucoma. Then neovascular glaucoma and lens-induced glaucoma. Definitely these should come in the mind. Then endophthalmitis and orbital cellulitis. These 5-6 are the broad acute painful vision loss. But if you write the others, that is of course a good one. Now, when we have a broad differential in the mind, how to approach the patient? How to approach? This patient is coming to you in emergency department. The first and foremost thing is taken the history of onset, duration, progress of the presenting symptoms. Onset, duration and progress. You ask the patient, this is acute. So patient will tell that it is acute, that within a day or 1 day or on the same day, the patient is having some symptoms. That is the onset, when the disease process starts. Duration, what happened during the disease process. That how much time, it was a sudden or it was a gradual building up and then it comes. And how it is progressing now. What is the current situation from the onset and what is the current situation now. That is onset, duration, progress of any condition. You have to ask, and when you write in the exam, in the Viva, then you have to start with the onset, duration and progress of the current problem. Current problem is pain and vision loss. This is the current problem. But then you have to ask the history of associated symptoms. So any history you ask, you don't ask just for the sake of asking. Every history of the associated symptom first, then history to rule out the differentials, then means the negative history of the associated symptoms of the patient's condition, and any negative history, past history, which can be related to the differentials which you are asking. Not just haywire, you start any history. Any history, a patient is coming with acute painful vision loss, आप उसे पूछ रहे हो कि भाई आपको नींद अच्छी आती नहीं आती, तो ये सब तो आपको symptoms आपको related you have to ask, right? So what are the associated symptoms in ophthalmology? In symptoms is of course pain, redness, vision loss, discharge, photophobia. Okay, you can't ask the history of itching ना, खुजली थोड़ा पूछोगे आप. You can't ask history of itching that when you're asking when the patient is coming with acute painful vision loss. That's of course a very biased thing. So what history you will ask? You will ask the history of course you will examine, you will see the patient redness, but in history you will ask redness, because every of these will have redness except optic neuritis. Optic neuritis per se will not have redness. So means when the patient is saying no redness, directly your mindset is going towards optic neuritis. So history, almost everything will have in your differentials in your mind. This should be the mind in your mind, and the history should be related to rule out what can be the causes. So if there is redness, you rule out optic neuritis. Okay. Now you will ask any history of in the past, if there is any history of gradual painless vision loss. Previous to the episode, any history when there is a gradual painless vision loss as it is going on for a long time. So that will give you that maybe the patient was having cataract or maybe glaucoma and suddenly the pressure has gone up. So this history is also very important. You will ask the history of discharge. If there is a discharge, everything is ruled out except it goes in favor of some minimal discharge in keratitis or maybe discharge from the orbit, then orbital cellulitis. Only orbital cellulitis and interstitial keratitis can have some discharge among the differentials. Now you will ask if there is an intolerance to, was there an incident before the episode, any photophobia, intolerance to the normal light? Because if there is a photophobia, that indicates that nerves of the cornea are getting irritated or uvea is irritated. So that if there is photophobia, your mindset will go towards that it might be a cornea infectious keratitis or uveitic problem. Any previous episodes or in this episode there is a colored halos. Now colored halos suggest that cornea is diffuse haziness. Diffuse haziness cornea goes in favor of increased IOP because that will have increased intraocular pressure. There is more pumping of the fluid into the cornea leading to diffuse edema of the cornea. So colored halos goes in favor of any increased high IOP, any acute condition will have colored halos. Not only primary angle closure, acute primary angle closure, can be any intraocular pressure. Secondary acute, everything can have colored halos in the patient. Then you can ask, of course you will see, but you will ask the patient all these. Then you will examine. I'm just going to history first. Any periocular swelling. Periocular swelling to rule out if there is a, your history wise, if there is orbital cellulitis or not. And of course lastly you can ask that if there is any pulsations and the eye is protruding out or not. For again, pulsatile for keratoconus fistula and protrusion for keratoconus and orbital cellulitis. So this is the history of associated symptoms, right? Then you will ask next the history, negative history, to rule out the causes. So this is in front of me. This is all the causes are in front of me, and I am going to rule out what history I will ask to rule out that a patient has infectious keratitis. I will ask the patient history of any injury. So if the patient says any injury to the eye or any contact lens, I have to rule out corneal ulcer. So any injury and any wearing of contact lens. Why I am asking this? So that I can rule out any infectious keratitis cause. Injury means trauma to the eye, because that is important one. Injury mostly for fungal keratitis, contact lens also for any keratitis, maybe acanthamoeba keratitis. Then history of any sinus infection. Sinus infection to rule out any sinusitis related ethmoid sinusitis. Or injury, of course. Injury goes for orbital cellulitis as well. Yeah, okay. Yeah, we are just see what we are dealing with. We are dealing with a patient of sonal acute painful blurring of vision or vision loss in an adult patient. I've just coined a term, some differential. I've noted some differentials of this patient, adult patient. Can be infectious keratitis, can be increased IOP due to any cause, very high IOP, acute primary angle closure or acute secondary closure due to neovascular glaucoma, lens-induced phacoglaucoma, phacomorphic, phacolytic, and so on, aqueous misdirection, uveitic related glaucoma, any hemorrhagic glaucoma, hyphema, any trauma to rule out any hemorrhage, pigmentary pseudoexfoliation, any endophthalmitis, panophthalmitis, and optic neuritis and cellulitis. I'm going from cornea to retina, optic disc, and then outside the eyeball, that is orbital cellulitis or keratoconus fistula. Then we noted the onset, duration, and progress. Then symptoms to rule out our differentials, and then I'm ruling out step by step any history to rule out our differentials. So I asked history of injury to contact lens, injury and contact lens to rule out a patient of corneal ulcers. Okay, then any sinus infection to rule out any orbital cellulitis. Then I will rule out any drug history. Why drug history, I'm asking? Anyone? Why add drug history? Or any recent this episode precipitated when the patient went in dark? For acute primary angle closure, because acute primary angle closure, there can be pupil block precipitated by pupil dilatation, mid-dilated pupil. Then to rule out neovascular glaucoma means any retina pathology. So I will ask history of whether the patient is having uncontrolled diabetes mellitus or uncontrolled hypertension or any cardiac problem. Because if there is diabetic retinopathy, hypertension retinopathy, any cardiac problem, there can be retina ischemia, and retina ischemia can lead to secondary neovascular glaucoma, which can lead to high IOP. For phacomorphic phacolytic, I've asked already any history, gradual painless vision loss. Trauma, again trauma injury goes in for phacotopic glaucoma. If there is a phacotopic glaucoma, means due to trauma there is subluxation. Now you'll ask for aqueous misdirection and endophthalmitis, any recent eye surgery. Very, very important. Now if there is a recent eye surgery and the patient is coming with acute painful vision loss, it can be endophthalmitis, panophthalmitis or malignant glaucoma. Malignant glaucoma is aqueous misdirection. Then uveitis can be so many causes. Now uveitis, for ruling uveitis, there's any other systemic disease like any granulomatous condition of the patient like TB, sarcoid, or if there's a young adult patient, maybe ankylosing spondylitis, Ritter syndrome, Posner-Schwarzman syndrome, any systemic condition, rheumatology condition which can precipitate acute inflammation in the eye, acute uveitis, that also we will rule out. Because I have in mind my differentials, I'm ruling out just by looking at the differentials. Okay, pigmentary glaucoma can be ruled out, that he has done, is this acute painful vision loss or blurring of vision coming after exercise? Because if a young adult is coming after exercise with very high pressures, acute painful, there can be corneal edema, that can be pigmentary glaucoma. Endophthalmitis, panophthalmitis, I told you, by recent eye surgery. Yeah, sonal, of course. Okay, optic neuritis, if there is no redness, then it goes towards optic neuritis. If there is a redness, then optic neuritis is generally less commonly associated. But optic neuritis, for optic neuritis, mostly multiple sclerosis. You can ask the patient of any other associated phenomena, increase during exercise, the symptom increase during painful eye movements, or that. For orbital cellulitis, negative history, injury and sinus infection already there. And critical fistula, always there is a history of trauma. So injury rules out many things. So what does injury rules out? Injury rules out, for injury you are asking injury for ruling out keratitis, infectious keratitis, for any phacotopic glaucoma, for any blunt trauma, hyphema in the eyes, hemorrhage in the eyes, for any endophthalmitis after post-traumatic endophthalmitis, or orbital cellulitis and keratoconcavinous fistula. So these are what the negative history or the past negative history to rule out our differentials diagnosis. So I have got a pretty much idea. I have my differentials, I have my onset duration progress, I have seen the SOS symptoms, I have ruled out history. So history, don't cram it. Just the main thing is to bring a differential diagnosis first, and then you build up the case according to that. Right? Now comes the examination part. Okay? Let us examination. Now examination is to confirm what you have noted down in the history. The examination should accentuate what you have done till now. Now examination, the first foremost thing in eyeball, the basic things, the basic examination you have to do first, you have to note down the visual acuity of the patient. of course for prognosis purposes, and to rule out, see how much he will gain, what is the current problem causing how much blurring of vision or vision loss. Like mild, moderate, profound vision loss is there, and that can tell the patient that how much the vision is there and what can we do to save that vision. Okay, and visual acuity, you have to check the projection of rays. Visual acuity you check by Snellen's chart, and projection of rays, if the patient from all the four quadrants, if the patient is not able to see the topmost letter of the Snellen's chart, you can ask the finger counting from 6 meter, 5, 4, 3, 2, 1. And the very poor vision loss, you can ask hand movements, or then perception of light and projection of rays. Now that is the basic thing you have to do. Then you have to do a general eye examination. In general eye examination, you can see for any protrusion of the eyeball. This is general torchlight examination you can do for any protrusion. You will check the eye movements. Now while you check for protrusion for orbital solitis and keratocofistula, so you can see it's prominent. Eye movements will be checked. Eye movements not for any cornea, IOP, for endophthalmitis, for orbital solitis and keratocofistula mainly. Because if there is orbital solitis, there can be ophthalmoplegia. The nerves and the muscles can be infiltrated and they can be having problem. Same goes for keratocofistula. The third nerve, fourth nerve, sixth nerve goes into the orbit, and that is supplying the eyeball movements. SO4, LR6 raised by 3. So that is your checking. Your examination is accentuating the findings. Now you will do your slit lamp examination. You will make the patient sit on slit lamp. And slit lamp, you can have a diffuse examination or you can have a slit light examination. For example, I'll just quickly, if I just show you that this is your slit lamp, right? In slit lamp, you have a diffuse illumination of the slit lamp. Diffuse illumination will show you diffusely when the patient is having redness in the conjunctiva, or any corneal problem that will be seen in diffusely. In our current set of scenario, eyelid problem, of course, that will be seen, but eyelid problem will not cause, no. Eyelid problem can have acute pain, but not vision loss. So we are talking about acute painful and vision loss in an adult patient. Then we can make a slit. We can make a slit and we can find out that if there is a cornea problem or if there is a cells in the antechamber, we can make a slit and then we can find out if there is inflammatory cells in a dark room or ruling uveitis. Cornea, if there is an ulcer, we have to measure the size of the ulcer for the prognosis. We treat the ulcer, then we will see how much the ulcer is spreading, or the shape of the ulcer, the size of the ulcer in dimensions we have to measure and write down in our notes. And then because when we treat, we have to see whether the dimensions are decreasing or not. Same, I can do this. I can do this Van Herrick method. What is Van Herrick method? You know, you make a small slit and you compare the cornea with the antechamber depth. Because in acute primary angle closure, the antechamber will be very, very shallow. That will be seen in Van Herrick's method. So slit lamp examination is very, very important. Now you will do a dilated examination as well. I'm not going into IOP right now, because if the corneal ulcer, IOP cannot be taken. You cannot do a contact procedure. You have to do a non-contact tonometry, but that is not much reliable. So slit lamp examination for cornea, and that will be corneal ulcer will be seen. Corneal ulcer, you have to measure the dimensions. You have to measure any epithelium defect. Initially, you can just check the sensations of the cornea also for corneal blink reflex, because in viral keratitis there can be decreased sensations. And general skin you can also check for any vesicles if there is a herpes zoster leading to infectious keratitis, herpes zoster keratitis. Then Van Herrick's method, I told you, Van Herrick's for the anterior chamber depth. Then of course lens will be seen. Lens will be seen for any cataract, like phacomorphic glaucoma, phacolytic glaucoma if there's a hypermature cataract, or any there is ectopia lentis. Iris you will see for any rubeosis iridis, because everything in your mind, the differential should be in your mind, and you have to rule out by examination if there's a rubeosis iridis means neovascular glaucoma. Then you have to look for fundus examination, which I'll tell you, for any diabetic, any retinopathy changes. You look for inflammatory cells for any uveitis. Of course, hypopion in the antechamber for endophthalmitis, panophthalmitis, even sterile cells in uveitis. Okay. Then even you can look for conjunctiva congestion. The conjunctival congestion sometimes gives a hint that what type of situation is going on. Now there can be a circumcorneal congestion. Every one will have a circumcorneal radial congestion around the limbus, but corkscrew conjunctiva vessels gives indication that can be keratico-cavernous fistula. Okay, what can we other find out? Any pigments or pseudo exfoliation. Okay, in the slit lamp you will see any dandruff material. Why? For pseudo exfoliation glaucoma. That can have acute pressure rise as well. Any pigment dispersion for pigmentary glaucoma, Krukenberg spindle, iris transillumination defects, like pigmentation in the anterior chamber. So this is on slit lamp examination. Now what ocular examination, what investigations you are going to do? You have to do some ocular investigations and maybe some systemic investigations if your differential is going towards that case. Now what ocular investigation you will do? You have to check the intraocular pressure. Now intraocular pressure, Goldman applanation tonometry to be done, but not in infectious keratitis, because that is a contact procedure. It should not be done in infectious keratitis. Of course, the pressure has to be checked. There is a secondary glaucoma, that is a major differential, so IOP has to be checked. Even the angle of antechamber, gonioscopy to be done. That is an investigation, but again not in infectious keratitis. Infectious keratitis, what you will do? You will do corneal scraping. So gonioscopy you have to do to rule out whether it's the open angle, closed angle. Because if it's a closed angle, which is indicated by Van Herrick's method, it's acute primary angle closure. Management will change. If it's an open angle, management will change. If there's a closed angle, acute primary angle closure, you have to first decrease the pressure and do iridotomy. So all the investigation, I'm not saying all the investigations will be done. It has to be ruled out as per the history, as per the examination. You will do investigations. Corneal scraping will be done only when there is a, of course you will see a indication cornea is having ulcer, then you will do a corneal scraping, right? Yeah, of course after slit lamp examination I forgot to say that's of course dilated fundus examination, but that is done that is done if there is an infectious keratitis, then no need for fundus examination because you know the diagnosis. Fundus examination is done for the optic disc you will do, and for any diabetic retinopathy or hypertensive changes in central lateral venous occlusion, hypertensive retinopathy, ocular ischemic syndrome, or endophthalmitis. If there is a vitreous haziness, endophthalmitis you have to check, because in definition of endophthalmitis vitreous has to be involved. And then corneal scraping for corneal ulcer, then ultrasound B scan. If the patient is having dense cataract, okay, you have to check the posterior segment. Only in those cases. Then when you cannot do a fundus examination for posterior segment evaluation, you will do ultrasound B scan. Not in all patients. You cannot see the retina. For example, if there is a phacomorphic, phacolytic glaucoma, dense cataract, you cannot see the retina, then you have to rule out, before doing the surgery, you have to rule out the patient is not having some posterior problem. You have to rule out the infection is in the vitreous or not. If there is endophthalmitis, you can't see anything in the vitreous cavity. You have to do ultrasound B scan to rule out that there is a endophthalmitis, because B scan will be abnormal in that. Okay, so that is a major ocular investigations. Not in all case, depending on which situation you are dealing with. And if your case is dealing with orbitocolitis or keratoconcavenous fistula, then you have to do imaging. You have to do imaging of eye, means imaging in the sense you have to do CT scan, MRI of head and orbit. Imaging of the orbit along with the head sometimes, because if the patient is suspecting of multiple sclerosis or any periventricular plaques you are suspecting, or keratoconcavenous fistula, then you have to do imaging of the head and the orbit to look for cavernous sinus problem as well. Maybe if it is a pulsatile proptosis, you have to do some digital subtraction angiography or magnetic resonance angiography. That will depend on how your examination is going on, as per the history and as per the examination, that what differential you have ruled out. Because imaging, you will not do imaging for any patient of ocular problem, na? Cornea, IOP, rise, endophthalmitis, wo to aapne already you have ruled out with symptoms, negative history and examination. Only for orbitocolitis to know the extent of the involvement, whether the orbitocolitis is in the orbit or in the cavernous sinus or not, because the prognosis will change. Or keratoconcavenous fistula, what type is it, A, B, C, D, then you have to do imaging. Thanks, Abur. So that is the basic investigations. Not do a battery of investigation. That's the basic one. And then the management, of course, will depend on what is your final provisional diagnosis. You have to come to a provisional diagnosis first. That what is this patient according to your history, examination and investigation, and the management will of course depend on that. So I'll just quickly, just to wrap it up, because we have 45 minutes, I've taken a short one. So if there is an infectious keratitis, you have sent a culture, you have to start a broad spectrum antibiotic. Like if there is a bacterial, then you have to start with cefazolin and tobramycin 1 hourly drops. If it is going, if you think that there is a hyphae in staining, you quickly have a cave stain and then have hyphae, you start with natamycin eye drops. Okay, so corneal management is topical antibiotics, antifungal. Along with that, you have to give cycloplegics as well, because the patient is having pain. Symptomatic treatment is also very, very important. You have to give cycloplegics to decrease the ciliary body spasm. Means you have to give topical homotropin or maybe topical sometimes ointment atropine. Then if the patient is having acute primary angle closure, if your diagnosis is acute primary angle closure, of course you have to decrease the pressure. If the pressure is very high, you have to put intravenous mannitol or oral astazolamide initially, because to decrease the pressure, that will clear the cornea, decrease the haziness of the cornea. And then the main thing will be iridotomy. The main thing will be iridotomy of the patient, laser iridotomy of the same eye and the other eye as well, because the other eye will also have risk factors, small eye, occludable angles. If there is a new vascular glaucoma, you have to decrease the pressure. In increase IB, you have to decrease the pressure. If there is a very high pressure, you have to give oral astazolamide or intravenous mannitol initially, and then you look for the cause, because in new vascular glaucoma secondary to diabetic retinopathy, that is a proliferative diabetic retinopathy stage, you have to do pan-retinal photocoagulation. Even for CRVO, you have to do pan-retinal photocoagulation. Even for ocular ischemic syndrome, you have to do pan-retinal photocoagulation, because the problem is in retina. Then in lens induced, you have to take out, you have to do cataract surgery, but before you have to decrease the pressure. You have to decrease pressure in everyone. Oral astazolamide or IV mannitol and some topical drops, and then you do cataract surgery, because if you don't control the pressure and do cataract surgery, suprachoroidal hemorrhage risk is very high. Now aqueous misdirection is after the cataract surgery. So you have to decrease the pressure, and ultimately if it's not resolved because it is a malignant glaucoma, either you can do laser hydrotomy or you can do vitrectomy. For uveitis, you have to give decreased pressure by IOP, and topical steroids have to be given, or maybe systemic steroid if there is a panuveitis. Cycloplegic is given with everyone because ciliary body spasm is there. Whenever there is infection, inflammation in the anterior segment, you have to give ciliary body spasm. You have to decrease the pain by decreasing ciliary body spasm by giving cycloplegics like atropine, homatropin. Now, if there is a hemorrhage, if there is a hyphema that is causing increase, you have to do a reclining position, 45 degree, so that the blood is going down due to gravity and the visual acuity also become clear. You have to give cycloplegics. You have to give topical steroids in blunt trauma with decreased intraocular pressure. Why topical steroid? Because there can be some inflammatory component as well. Why is cycloplegic? To decrease the ciliary body spasm. Now, if your diagnosis is as endophthalmitis, then endophthalmitis, post-traumatic or post-cataract surgery, you have to do intravitreal injections of antibiotics. See, the treatment will depend on what is the diagnosis. If there is a panophthalmitis, then you have to do systemic antibiotics. And if it doesn't resolve, then evisceration has to be done. For optic neuritis, again for the cause, intravenous steroids for multiple sclerosis. For orbital cellulitis, again you will give culture. Now you can write to this culture as well. Systemic culture as well. Culture for orbital cellulitis. And then the treatment is intravenous antibiotics. And keratoconcavenous fistula, you have to do imaging and all, and ultimately embolization is done. You have to refer the patient to neurology. So every differential, again to sum up, every history, whether associated symptoms or history of negative history or your examination or your investigation and ultimately provisional diagnosis should come so that to rule out what the main differentials you have kept in mind before starting the history. So that is the main thing. The history has to be based on what is the differentials in your mind, because your entire case will depends on all the first 5 minutes, the thought process of how you're going to approach the patient, history wise, examination wise, and investigation wise. I think, yeah, it's 40 almost 45 minutes. That is a patient, how we deal with acute painful vision loss in an adult patient. All right, thank you very much. Again, I end up with happy Teachers Day to all my teachers and to all my students as well. Best wishes.